Okay, order, good morning. This is the Health and Social Care Select Committee for the second day in a row. Yesterday we had the Permanent Secretary and the Secretary of State. Today we are concluding our inquiry on pharmacy. So we are looking at community pharmacy and we are looking at hospital pharmacy. We are looking at the sector, and as is tradition, we conclude this inquiry by having the Minister. So welcome again, second week in a row, to Right Honourable Dame Andrea Leadsom MP, who is the Parliamentary Secretary for Public Health, Start for Life and Primary Care, otherwise known as the Pharmacy Minister, which is why you are here today. We have Dr. Amanda Doyle, who is also back for the second week in a row, can't get enough of us, National Director for Primary Care and Community Service at NHS England, and we have David Webb, who is the CPO, the Chief Pharmaceutical Officer at NHS England. Thank you very much for joining us. I will place on the record that I am one of Andrea's predecessors as the Pharmacy Minister, and one of the best jobs in government, and I love doing it. Anybody else have anything they wish to place on the record?
I was Pharmacy Minister for a short period.
James was Pharmacy Minister for a short period as well. Excellent. Andrea, let's start with pharmacy first. The pharmacist will see you now. The Company Chemists Association sent us their Pharmacy First, the first month. Nearly 50,000 Pharmacy First consultations provided in the first month by their members. There were 2.5 times more consultations in more deprived areas. Nearly a third of all consultations were provided outside of typical working hours. This is good. P3 Pharmacy magazine, the front page of it, if I could use a prop I would. Pharmacy First takes off is the front page of their magazine the other day. And just to give you some quotes from this, there's a palpable sense of expectation and a belief that this is a make or break moment for the sector to demonstrate that it can step up to the plate. So I thought it was a really, really nice quote. And then Aid Williams, who is a Bedminster Pharmacy in Bristol, said there's a lot of positive excitement around this. It's something we've asked for over a long time. Of course there are logistical concerns. IT is a big one for some, but it's going to be transformative, not just for pharmacy, but for all primary care stakeholders. And then the front page of Pharmacy magazine, the voice of community pharmacy, Pharmacy First, a promising start. The signs are that pharmacists on the ground have made a promising start delivering the service. Jackie Lewis, who's a pharmacy owner in Exmouth, said it was an intense period getting it up and running, but there's been a lot of positive energy from local surgeries and pharmacies in their primary care network. So these are really good, really good. Yet we have these various negative voices. I'm not saying they are negative people. They're just giving a different side to the wider sector. And I just wanted to say that, in the CCA, Company Chemists Association briefing sent to us, there are now 1,110 fewer pharmacies in England since 2015. Since the start of the 23-24 financial year alone, there's been a net loss of almost 400 community pharmacies in England. And Paul Rees from the National Pharmacy Association told the Health and Politics podcast that I do, 72% of its members are in deficit. And he says the funding model is broken, a new deal is needed. And then just finally on this, Janet Morrison, who is the Chief Executive of Community Pharmacy England, told us as part of this inquiry that there needs to be a contract framework overhaul to remove the ironclad ring fence around funding. That was in evidence that she gave to us. So really positive press around Pharmacy First, really positive statistics, yet we have parts of the sector saying we're closing, we can't make the sums add up. And I'm just trying to understand where the truth lies. A long question, but it had to have that context. Minister, what were your reflections on all of that and where Pharmacy First has begun?
Yeah, well, first of all, thank you very much for having me again. And I think, universally that Pharmacy First has been welcomed. Over 95% of all pharmacies have signed up to it. They didn't have to. They are getting a part of a £645 million budget over 2 years to support Pharmacy First, which includes a £2,000 set-up fee, £1,000 a month, £15 a consultation, etc. The IT challenges, I'll defer to Amanda to explain exactly where we are on that, but there have been one or two issues which I understand were not the fault of the relationship between DHSC and the pharmacist, but rather it was an issue of the pharmacist's own supplier of IT who have made some changes as a result which were unforeseen, which has slightly delayed the digital connections, but only very slightly. And so I think Pharmacy First is a fantastic initiative, and we are seeing, as you rightly say, a huge number of new consultations taking place, and it is part of a longer term plan within the NHS long-term plan to see much more clinical service taking place to use the skills of pharmacists. So it's a very positive thing. To your point about closures, the government is responsible for making sure that people have access to pharmaceutical services. What we're seeing is that still 80% of people live within a 20-minute walk of a pharmacy, and there are approximately twice as many pharmacies in more deprived areas than in less deprived areas, which is all good news. Access remains good, and in that year from early 23 to early 24, we've seen about 1,500 closures and about 1,100 new openings. So it continues to be a thriving market, but of course pharmacies are private businesses and they have a contract with the NHS to provide services, and that therefore means that things change, people retire, they want to close, they want to rationalise and so on. But in addition, we also now have 400 distance dispensing pharmacists who will deliver to people's homes free of charge. And so that is a sort of a new initiative that people, if they're finding that there's temporary queues or if they're finding that a pharmacy is closed, they will be able to go online and access medicines through those distance pharmacists. And then the final point I'll say, long answer to your long question, is that of course where there isn't a pharmacy within a reasonable time distance or geographic distance, then GPs can actually then apply for a license to open a pharmacy, a dispensary themselves. And that does happen in more remote areas where there isn't that sort of market for a pharmacy to be able to be run in a sustainable way. And there are some payments, some support payments made to some pharmacies where they are in areas where it is difficult to sustain that pharmacy. So I think the overall package of support and also provision remains very strong.
Okay. So is it the case then that, you're right, there's been a large number of closures and also a number of openings, and the gap is about the 400 that I quoted. So is it the case then that, given the coverage is what it is, which you correctly say, given that there are online offers, which some people, a lot of young people particularly, more than happy to access, is it the case that given that mixed economy, given the coverage is what it is, that the government is relaxed if there is some rationalisation in the bricks and mortar estate of community pharmacy, because as long as the access is still guaranteed, then the government is relaxed if some private businesses don't make it?
I wouldn't phrase it like that. What I would say is the government is responsible and takes very seriously the responsibility to ensure access to medicines for all residents here in the in England. That is very important. And what we do find at the moment is we monitor very closely the closures and openings, and of course integrated care boards have a role in providing licences for new pharmacies, and local authorities have a role in doing an assessment of the needs of their local population. So we monitor it very carefully and very closely, but what we're not about is ensuring that a pharmacy never closes or that another one definitely opens, because pharmacies are private businesses. But I think the whole Pharmacy First initiative, added to the previous increase in pharmaceutical interventions or within pharmacies to monitor blood pressure and to provide oral contraceptive advice and so on is all part of a move to enabling many more clinical services to take place in community pharmacies. And what that will do, we believe, will increase or will reduce the pressure on GPs by about 10 million appointments a year just from Pharmacy First alone.
Yeah, 10 million.
10 million,
yeah. I'm glad you mentioned ICBs, because what would your message be to them and primary care networks is that do they have enough pharmacy representations on the integrated care boards, for instance? Are you comfortable where that is? And are you comfortable that they are doing that mapping to make sure that access within X miles of people's homes, there is a bricks and mortar pharmacy? What is your message to ICBs about how they should be having an overview?
Well, top level, I would say to ICBs, primary care is absolutely crucial. It is the thing that every single one of us needs, and that includes pharmacies, it includes GPs, it includes opticians, it includes all of the primary care that we all rely upon. And so I do think that some ICBs are very, very good at scanning across and making sure that the provision is there. Others have perhaps tended to be a bit more focused on, emergency care and elective care and so on. And it is very important that they ensure that the surveys that their local authorities do of the needs of the local population are taken into careful account. So some of the, I regularly meet with colleagues to talk about issues in their own area, and one of the things that's been raised with me is the time it takes for an ICB to agree to give a new licence for a new community pharmacy to start up in a particular area. So things like that I would urge ICBs to make sure are fast and that we're not unnecessarily delaying, particularly if a pharmacy shuts down, let's say, because as the committee will know, there's those that are owned by the big multiples, then there's those that are sort of chains of pharmacies, and then there's the small independents. So quite often, if due to rationalisation or the retirement of a small independent, if that leads to a closure, it may well be that there'd be somebody else willing to come in straight away and take over that premises and then have a sort of a continuous flow. And there, I would say that the ICB should really make sure that they address that as quickly as possible to provide that continuity of care for the community.
Yep, I think that's a very clear message to them. Let's bring in Dr. Amanda Doyle from NHS England. And I think, it's been said by NHS England that Pharmacy First is something that you expect to see ratchet up and up as more knowledge among the public becomes of it being there. Do you expect to see it grow in terms of the number of conditions that it can treat? What is your ambition for Pharmacy First? Where does it go next, I guess is what I'm asking.
So at the moment, as you know, the clinical pathways, the new clinical pathways in Pharmacy First treat 7 conditions, not necessarily minor conditions, but generally uncomplicated and high volume conditions. We need to embed and establish that and evaluate it, particularly is it meeting patients' needs, is it delivering outcomes which mean they don't then need to seek an appointment with their GP. We've got an evaluation commissioned around antimicrobial resistance, looking at total quantity of antibiotics prescribed. Are the pathways the right ones? Are they effective? That is all part of the package, but we're quite quickly starting to think about the future, and we're not going to have the outcomes of those evaluations.
How quickly is quickly? You're not concerned, are you, about pharmacists? Some have said that pharmacists will overprescribe, and that will add to our problem with antimicrobial resistance. The evidence from elsewhere in the world doesn't back that up. You're not concerned that that's a worry, are you?
So the evidence doesn't back it up, and the antibiotics can be dispensed by pharmacists according to patient group directions, which are quite tight clinical protocols. Expert clinical group worked them up. NICE guidance is taken into account. They are the same protocols that would be in use usually in GP practices without the mechanism for it. And so I would expect that there will be no change in whether a patient gets the antibiotic, regardless of whether they went to a GP practice or a pharmacy. But I think there is a duty to properly evaluate that, and the National Antimicrobial Resistance Board's been involved in looking at how we will evaluate that, and it's really important that we don't inadvertently contribute, but we are not expecting to. We're expecting to gain reassurance. Okay. And this is particularly important because, as you know, we are also concurrently running independent prescribing pilots in pharmacies across the country, and we know that all newly graduated pharmacists will graduate as independent prescribers in 2026. So actually starting this process with Pharmacy First with a really formal evaluation will absolutely help us to move on as that happens. We are also supporting training 3,000 pharmacists this year, existing pharmacists, to become independent prescribers.
Okay, hold that thought, because I think Rachel's going to come in with that in a minute.
That up later.
Just coming back to the money. So, a 30% real terms cut in funding since 2015 is a reality. Now, Janet Morrison, who leads Community Pharmacy England, formerly the PSNC, the Pharmaceutical Service Negotiating Committee, which negotiates the contract with you on behalf of community pharmacies. She said the crucial role of pharmacies in providing essential healthcare services to communities is on the line. The financial pressures on pharmacies are extreme and show no signs of improving. CPA has deep concerns about the financial impact of the increase in the living wage that it will have on pharmacy. It's not sustainable to expect pharmacies to absorb these additional costs. A failure to act to correct some of this will see many more pharmacies closing through 2024. So, given that, I said to the Minister her call around there being an overhaul of the contract and addressing the financial pressures that they're facing that are leading to closures, how relaxed are you about a rationalisation of the bricks and mortar estate?
So, as long as there is, as the Minister says, access for the population, that's the important thing from our point of view. And some of the rationalisation of the estate is when pharmacies were very, very close to each other. There might be two on the same street. Sure. At the same time, we have had that 9% reduction over 5 years in the number of community bricks and mortar pharmacies. We've concurrently had a 9% increase in distance selling pharmacies who offer a service for people who perhaps work all the time when a pharmacy might be open, who can't get out or immobile. So we are seeing a balance in a different way of offering a service. But equally, if our strategy, which it is to increase the role of community pharmacy as a first-line provider of clinical services to the community, then it's really important that we do have that estate. We do have 80% of the population within 20 minutes walk of a community pharmacy at the moment. There are twice the number of community pharmacies in close proximity to people in deprived populations, so that's really important. And we have Pharmacy First is the new service, and it's the big one, and it's accompanied by big investment, but we've been slowly building up a range of other services. So pharmacies now not only dispense all of our medication, but they offer needle exchange and supervised consumption and smoking cessation and weight management. They do new medicine services for people on complex medicine regimes. They do discharge medicine services, do significant numbers of our seasonal vaccinations. Pharmacy First, I've mentioned the blood pressure service. We've had well over 900,000.
What they would say is they can't do it if they're not there. They can't be your shop front if they're not there.
No, and we are absolutely committed that community pharmacy remains embedded in the community. And so we look closely at movements in the market.
That's a good line to stop that, to pause that there. And let's bring in you, David Webb, and then we'll bring in Rachel Maskell. If I was to produce a risk register for Pharmacy First, I would put medicine shortages right at the top of it, especially how it then interacts with the wider primary care and what the Minister rightly said about it's designed to take the pressure off primary care or general practice. If you go into a pharmacy now to redeem your prescription, this is something I raised with the PermSec and the Secretary of State yesterday, as I'm sure you're aware, then there's a regular conversation that they will say, we don't have your item due to national shortages. There is a replacement item, but I can't give you the prescription for that. You have to go back to your GP to get that replacement prescription. That then pushes those people back to general practice. If you talk to GPs, they'll say, this is happening all the time to us. So what we've received in evidence we published yesterday from the Community Chemists Association is that UK generic reimbursement prices are now so low that manufacturers are prioritising other global markets which they think are more favourable, and then that directly impacts the availability of, and therefore patient access to, medicines. So I just want to know from you as Chief Pharmaceutical Officer, how seriously do you take medicine shortages as a threat to the pharmacy sector?
Thank you, Chair. I take them very seriously as a threat to the sector. But I think more importantly than a threat to the sector is the impact on patient experience and the stress and problems that shortages create for patients. In terms of Pharmacy First more specifically, because that's a PGD-based mechanism to provide prescription-only medicines, the flexibilities were built into those PGDs to allow some movement between formulations if an item moved into shortage, so that there's an approach within that enables pharmacists to use their judgment to provide potentially a different formulation if the one that they intended to provide under the PGD was not available. So there's an element of flexibility built in to smooth out those issues that might otherwise affect the operation of Pharmacy First. I think more generally on shortages, there is a significant effort, if you like, behind the scenes and with colleagues in the Department of Health and Social Care to address situations as they manifest or before they manifest as shortages. So there's a medicine supply team, there's also a medicine shortages response group. Much of that work isn't visible because it actually mitigates the problem before it manifests. But the important thing is the range of levers that are available to address shortages in those circumstances. So, for example, there's a system of providing medication supply notifications that are graded in terms of the severity of their impact. There are relationships between suppliers, between the department and suppliers and with wholesalers to understand the pattern of medicines use and the nature of the shortage. And then ultimately there are things called serious shortage protocols which enable community pharmacists to supply different products in specific circumstances in response to a shortage.
They're quite limited at the moment, aren't they? Is it not the case that you are going to ask, or the Minister is going to ask Parliament, with your advice, to increase the number of serious shortage protocols?
We've seen developments in serious shortage protocols from very narrowly defined tools into things that have a greater range of flexibility to address some of the shortage situations we've had. So I can see the scope for enhancing that approach. I think the important thing about SSPs in some way is their precision, because they are built on an understanding of what alternative products are available. And so if there's resilience in the supply chain for the alternative product, an SSP can very quickly sort of direct towards that. And then when the initial shortage issue is resolved, they can be deactivated very promptly in a way that maybe prescribing guidance takes longer to formulate and then to remove. So there are some advantages to the nature of SSPs, whereas as a practicing pharmacist, I might not be cognizant of the supply chain situation of all the alternatives, whereas within an SSP that there's an assessment made of the resilience of the alternatives, and therefore they point to products where we won't create, if you like, another shortage because we've hopped from a shortage situation into another one.
All right, that's good. Thank you for that. Let's bring in Rachel Maskell now, various subjects, not least our workforce.
Thank you very much. Thanks for coming today. Yes, I want to focus on workforce issues predominantly, and we had the privilege of holding round tables and meeting with the whole pharmacy community, as well as funding pressures which they described. And I would urge you not just to leave it to the market, but to make some interventions to bring relief there. They also described the workforce pressures which currently exist, but also will for the foreseeable future. In particular, concern around clinical placements for students, with the pressures that pharmacists are under, being able to host students provides obviously a lot of time taken out, but also if apprenticeships are to be introduced in the future as well around the professions, then clearly that will bring additional pressures. If I can turn to Amanda Doyle to start with, how are we going to address the ability to provide good clinical supervision to our future generation of pharmacists?
So if we are expanding the workforce, which the long-term workforce plan says we are, and we already have been, and we're looking to support pharmacists to develop and extend the range of clinical skills particularly independent prescribing, then it's really important that we recognise not only support for clinical placements for foundation year pharmacists in community pharmacies as well as in hospitals, so that we ensure that this pipeline, it's really important that we support ongoing learning and development. And as I mentioned earlier, through the Pharmacy Integration Fund, we are funding pilots of new clinical services. We're funding clinical leads, clinical pharmacy clinical leads within each ICB, so that there is support, professional leadership and development there. We're funding, this year we funded 3,000 places for independent prescriber training for existing pharmacists, because obviously we will have a gap if all new pharmacists do it, and we want to catch that up. And we're recognising the importance of the infrastructure that needs to be in place to support those clinical placements, so that recognising that students will often need to travel to clinical placements, for example. And so all of that is part of our commitment to our pharmacy workforce, which extends not just to pharmacists, obviously, but in support for using skill mix more effectively in pharmacy, so better use of pharmacy technicians, increasing numbers of pharmacy technicians, both in clinical services, so within primary care or hospitals, but also within pharmacies themselves, so that we can free up the pharmacists to carry out a lot of the clinical service delivery that's part of our future strategy for the service.
Can I just ask a specific question? As you mentioned, ability to undertake placements. Will the department be looking at introducing the Learning Support Fund, which is obviously applied to other health professionals like nursing, AHPs, in order to help facilitate the profession being able to, if I can just come back to you, Amanda, on that, and just that whole kind of workforce development or NHSE.
Pharmacy is outside of the scope of the Learning Support Fund because it only applies to those courses that were eligible for an NHS bursary prior to 2017. I can't answer as to whether the department will be looking to extend that. That's not an NHS England decision.
Perhaps I can turn to the Minister on that point then.
And the straightforward answer is these things are always under review, but I, at the moment, am not currently aware that there is a plan to extend it.
Okay, I'd like to turn to a more substantive issue now, at looking at certainly what you've described around different professions taking on, within the pharmacy community, taking on different roles. There is real concern around, as we're seeing more skill mix, there is a blurring of the boundaries, professional boundaries, between the different professions, and that this then brings into question how that is being addressed through a kind of prism of patient safety, but also regulation, to ensure that we are seeing regulation addressing the different competencies which are attained, and we're not seeing skill drift or indeed people working above their competencies. How is the department looking at this whole issue around expanding the roles to ensure patient safety, but also maintaining those very clear and distinct clinical boundaries between the professions?
You're addressing that to me, Rachel, yes. So, I mean, that is absolutely integral to everything we do. Patient safety is absolutely key. But you're also quite right that what we're trying to do is to improve access for patients, and therefore to enable different clinicians to be able to work to their training levels, whereas in the past they haven't necessarily, and we've seen that with dental therapists, and we see that with pharmacists. And so in fact there is some secondary legislation coming through, and I have a feeling it's in mid-April, but don't quote me on that, and that is to expand, but very, very carefully, the role of pharmacy staff to be able to take on more, but in a very, very controlled way. And so I do really want to assure anybody who's dialed into this that patient safety comes absolutely first. There will not be skill drift. What this is about is to improve access, to enable what are superb clinical skills to be made better use of in community pharmacy. One, because that's closer to the patient, as I've said, 80% of people live within a 20-minute walk of a pharmacy, but two, because those skills are available and have in the past traditionally been underutilised. So this isn't about, in any sense dumbing down. It's not about skill drift. It's not about any sort of risk to patient safety. It is about improving patient access to those skills.
Thank you. One of the key things around regulation is around, obviously, the title of a professional, and recognition of that title enables and empowers the patient to understand the services that they're getting. How is that being communicated if we are seeing an increase in the range of competencies that clinicians are working to the patients, so they understand the parameters of the care they're receiving?
Well, I guess there's sort of two answers to that. Is that there's number one is the patient's perception and the patient's own control of their own care, and the other is the reality of it. So just from the government's point of view, there will be very strict, obviously, patient safety focused controls around what different clinicians are able to do. And a key part of the Pharmacy First IT upgrade was to ensure that pharmacists would be able to access patient records, to make sure that any prescribing done by a pharmacist would be in full knowledge of any allergies, any intolerances, any other prescriptions, etc. So that's the sort of the control aspect of it, top down. But the patient's own awareness is obviously very important too, and there are a number of different public health campaigns. We've done a lot of media around the new Pharmacy First and the ability to go to a pharmacy and be treated for 7 common conditions. So that's, if you like, putting the power into the hands of patients to see that, well, actually, I could call the GP surgery and perhaps not see someone for a couple of days, or I could pop into my high street pharmacist, see somebody there who is perfectly able to prescribe for me something for my sore throat or my earache. So it creates patient choice, it improves patient access, but there is no compromise in terms of patient safety.
Thank you. And just a further question. Clearly, if people are working with new competencies, which will be granted whether through the regulations, obviously I'll have a look, how will those posts be evaluated against the Agenda for Change job evaluation scheme?
Is that a question for you, perhaps?
Posts within
Amanda?
Pharmacies.
Yeah.
So the Agenda for Change system is in use for NHS employers. So most of primary care don't use the Agenda for Change system, so general practice tends not to, pharmacies don't, dentists don't. And so
the roles themselves, a pharmacy technician can work in a hospital pharmacy as well. So
the information that is used within the hospital sector, for example, to evaluate the role of a pharmacy technician is openly accessible to people, perhaps introducing that role in a community pharmacy or another primary care provider who want to receive some guidance, but ultimately responsibility for deciding pay rates is with the employer.
And there could be a number of jobs needing re-evaluation, clearly, if they're taking on more competencies to within their brief.
That's right. As we develop roles, introduce new roles, introduce extensions to roles, then some people's jobs will require re-evaluation.
And I want to pick up an issue which I've kind of heard thematically through our inquiry around clearly Pharmacy First and also discussion we've just had, is that we're now seeing pharmacists clearly expanding their role and providing diagnosis on certain conditions, while we're also seeing doctors clearly involvement in prescribing being quite extensive, including drug reviews often having to go back to a GP for sign-off before it can then come back, or the provision of alternative medicines going back to a GP before a pharmacy can then dispense. I just wonder if I can turn to you, David. We seem to almost be flipping roles as opposed to really focusing in on the specialism in which pharmacists can provide. Is there more that can be done to ensure that there is that distinction between the professions, but also to ensure that we're getting the maximum value out of the professional competencies that pharmacists bring?
Yes, I think, this partly goes to the concept of a sort of one workforce model within an integrated care system, in the sense of knowing what each partner is contributing, and specifically in the pharmacy arena, understanding what each sector of pharmacy contributes and moving beyond a sort of identity that's defined by your sector of practice and one that's more defined by your clinical contribution wherever you choose to deploy it. I think with Pharmacy First, it's a very specific set of clinical conditions.
Could expand.
It could expand, and I think it's a great platform for the future. It's a great way to express it to the population as well as to what this is about. But it's a very defined set of clinical conditions where we have worked with expert groups, multi-professional expert groups, to look at the treatment options and then how those are phased depending on the presentation of the patient. That the point you make, I think, about, if you like, messages going back to GPs for providing alternative products often relates to a shortage situation, because in the absence of an SSP, community pharmacist has to dispense what's on the prescription.
Sure, but also a pharmacist would probably have greater competencies within pharmacology than a general practitioner. So it's how we maximise the relationship, not just uni-professional, but integrated across the professions is really important.
And that is the essence of the sort of one workforce thinking. And the other, I think, relevant point is, of course, that we have pharmacy professionals working in general practice or in PCNs as well, and I think there's an element of coordination through that can be enhanced as this sort of pivot between different parts of the pharmacy provision in a given geography.
Thank you.
All right, James Morris.
Thank you, Chair. The direction of travel with Pharmacy First and a myriad of other things is to expand pharmacy, expand access. But the premises themselves are largely set up as being retail premises. We've had evidence that there's quite a lot of variability across the kind of pharmacy estate, if you like, in relation to consultation rooms and other infrastructure. I just wonder, David Webb, whether or not you've done an evaluation of the adequacy of the pharmacy estate to deliver the different services that are in Pharmacy First, and thinking about potential future expansion, whether there's a kind of evaluation of the estate and its capacities.
Thank you. The requirement on community pharmacy is to have a private consultation room where the participant and the professional can hold that conversation without a risk of it being overheard by other people. So that is an absolute requirement. That must be in place as part of the contractual arrangement. And
what does that get monitored? So, how do you know whether or not is there going to be an inspection regime or some way of determining whether that somebody's fulfilling that element of their contract?
It's a legal requirement, isn't it?
It's a legal requirement.
Yes, it is a legal requirement to have it.
Right.
If there were ever concerns, then they would be addressed at the ICB level through the usual performance mechanisms that relate.
So Pharmacy Commission's delegated to ICBs now, and each ICB is expected to have an estates, an understanding of their estates and a strategy for their estates, including primary and secondary care, which includes everywhere that we commission clinical services from. Increasingly, that includes pharmacies. The challenge is real, so it's a requirement of the contract that the pharmacy can offer a private consultation room where people can either have a consultation or discuss an issue, where both the pharmacist and the patient can be sat down. Pharmacies will always have access to computer records, patients' national care record, for example, and in future more of the clinical record all available in that room. As we look to, and pharmacies are taking up the opportunity, as you've heard from the various reports at the beginning, to expand clinical services rapidly. Obviously, for lots of pharmacies, that means more than one room. And so we do recognise, and part of the set-up payments for things like Pharmacy First are about not just training the staff and getting yourself ready, but ensuring you can deliver from an estates point of view and an infrastructure point of view the services that you want to take on.
Just on when you say the set-up fee, so what element of that set-up fee would be about investment in the premises?
So it's not broken down that specifically, because obviously that will vary so much from pharmacy to pharmacy, so the big multiples who might be in a big store can much more easily repurpose space. So it's up to individual pharmacies to meet their needs. Of course, because pharmacies are also commercial premises, so they differ from general practice in that general practitioners are not allowed to offer private services to their registered patients, where pharmacies are often, for example, lots of pharmacies might offer a travel vaccine service for which they maintain a consultation room and they're generating income. But alongside that, they're also increasingly offered NHS commissioned clinical services for which they also require that space.
Minister, just on the basis that the premises are going to become more important as we want to put more services through them, do you think there's we've heard evidence or an argument that pharmacies should have an establishment fee beyond the setup fee, so there's actually a contribution to their capital investment from the government?
Yeah, so there used to be an establishment fee, and that was phased out some time ago.
Do you think there's an argument for bringing it back?
Personally, I think the basis on which pharmacy is a private business with a contract with the NHS is the right approach, so that those private businesses can offer other services to members of the public. I don't think it's right that the taxpayer should take on the burden of updating or upgrading those premises. I think that Pharmacy First is a very good example of how, since so many, almost all pharmacists have taken up the Pharmacy First contract, so they have decided to do that, and they received a £2,000 fee to help them to get up and running, and then are receiving £1,000 a month. So that was obviously attractive, and as Amanda says, that could perhaps be used to clear space out of an existing room to create a consulting room or an additional consulting room. Could be used to sort of redecorate it.
Would you accept that there is the nature of the pharmacy setup as it's traditionally been may well be a barrier to future expansion of services? So we have Pharmacy First, where we're directing a number of clinical pathways into pharmacy, but isn't there kind of there's going to be a kind of a barrier, a cap on what is possible in the way in which pharmacy premises are currently configured?
That will be some and some. So in a major in a major, huge store where pharmacy is one element of it, there may be room to expand that significantly if the demand is there. But I would go back to the fact that local authorities do, I think it's every 3 years, an assessment of the needs of their population. Yep. And it's for ICBs to then facilitate the opening of a sufficient number of community pharmacies. Now, I would say that the downside of that is you do end up with periods where if a pharmacy has closed because the owner has decided to retire or to rationalise a number of stores within a chain, then you do end up, unfortunately, with a period where the 1 or 2 remaining pharmacies in the area have got queues. And I do hear a lot about that from colleagues as well as from constituents. I've had those issues in my constituency too. And so I think it is then for the ICB to rapidly ensure that anybody else who wants to apply can get that licence quickly. I don't necessarily think we should be changing the model so that somehow we end up where the taxpayer is taking on the burden of upgrading premises to deal with the changing facilities. But equally, I think with the 7 common conditions, at the moment and for quite some time, we will see that there is the capacity within pharmacies to deal with those consultation opportunities. And as I've said, they receive a payment of £15 per consultation, so that's additional income in, and that is saving, potentially up to 10 million GP appointments a year. So it's a good story overall, but I wouldn't accept that the taxpayer should pick up the bill for upgrading individual pharmacy premises.
Okay, I mean, there were obviously perverse outcomes to the establishment fee, and that you've got clustering, which is not necessarily helpful to anybody. I just wonder whether a more targeted fund to help community pharmacies exist and therefore make the most of Pharmacy First may be something that the NHS England, the government, may consider. So yes, there is an upfront payment, and there's an ongoing payment, which is not ungenerous. But if you think of the expenditure required to buy some of the kit, for instance, so a pharmacist traditionally would prescribe for an outer ear infection something over the counter, but they can now, as I understand it, prescribe something for an inner ear infection. You obviously need the right piece of kit, which the clinician in me doesn't know, or the non-clinician in me doesn't know what it's called, but you have to buy that piece of kit, right? And that doesn't come for free. So I just wonder whether, if you are a multiple and you have access to funds to make that kind of investment, happy days. If you don't, I wonder whether there could be something that they could tap into, and that might be something you would consider.
Yeah. So
more targeted, I
guess.
Yes.
So there is the availability of financial support for pharmacies
right.
in areas which are very difficult to maintain a business, and that is, I think, probably relatively sparingly used. And certainly, I think one of the key reasons for Pharmacy First being only 7 common conditions is because there needs to be a bedding in period.
Right.
You wouldn't want to open the floodgates and then find, pharmacies have queues of people looking for appointments for various different things. So I think it's been a very careful and measured rollout of something that is just wholly good news for patient access and patient provision, whilst at the same time not overloading pharmacies, recognising some of the points that James makes and you make about, if you need to buy pieces of equiment, or
otoscope,
indeed,
isn't it?
Otoscope, exactly.
Now. That's what looks in the ear, isn't it?
Yeah, exactly. Yeah. But so it's a very valid point, and obviously we literally rolled out Pharmacy First from the 31st of January, wasn't it? Yes. And there are still, 1 or 2 teething issues with the technology, which I'm sure Amanda can fill the committee in on. But so it's still early days, but actually the evidence is good that it is so far a success. It's been welcomed. I've had a few letters from colleagues who've had constituents who've been passed back to the GP, then back to the pharmacy. Now that's not desirable, but obviously it's very early days, and we would expect those sorts of things to settle down. But it needs to be very carefully monitored, and issues like, the sort of the structure of the pharmacy itself, the need for equipment, and so on. All of those things will be under careful review.
That's good to hear. Did you want to?
If I could just pop in on a question, you said that there were 50,000 appointments kind of in its opening concept, and yet your ambition is 10 million. That's a 200-fold increase. Clearly, if people are going in such volume to see their pharmacist, there needs to be other facilities that are made available. For instance, waiting. We're talking about people that are poorly, and I've seen people queuing up in the street to go and see their pharmacist. So I don't know what consideration there would be around providing better care for those individuals who are going to pharmacy first, which again makes the point around some form of establishment fund to ensure those premises are fit for purpose, to ensure that not just the service but the care is available too for those patients.
Yeah, so you make a really good point, and of course that will be carefully monitored. I didn't put the 50,000; that was actually the chairman,
That's right.
So
yeah.
not my numbers. But yes, the idea is that what the modelling was to try to get to freeing up 10 million GP appointments a year. So it was that was where the 645 million, so it sort of worked backwards from the target number of freeing up GP appointments. And that, of course, was looked at with capacity in mind. And so there is a target, and I was just trying to find it here, but perhaps one of my colleagues has it. So I think it was in the first month of operation was 1 consultation. In March, it's 5 consultations. And then each month it rises to, it's something like 1,000 consultations a month. Is that right, David? Would that be about the numbers?
I'm not sure it's projected.
There's a really steep. I say obviously it's been running about since the 31st of January, so 8 weeks maybe. We started off with having relatively low expectations of the numbers that community pharmacies could deliver in the first few weeks, but that rises really rapidly up to the maximum capacity we would expect to be able to get from pharmacies in October. So in advance of winter, we hope to be at the maximum. We've got just short of 10,000 pharmacies taking part, all of whom, as we've heard, are enthusiastically embracing this and are. We've had a public media campaign which launched in the middle of February, finishes this week, which is TV adverts, radio, billboards, etc., letting the public know. And we deliberately delayed that 6 weeks because we didn't want everybody turning up on the first day. But actually, this is the sort of service that once people know about it, once they get referred by their GP once, maybe they'll try it again straight away next time. So we do want to let pharmacists get their systems embedded, get the staff used to it, and then ramp it up.
But my particular point is clearly if there's high demand, which is obviously what you're looking to, then ensuring that the care of those individuals, for instance, in waiting for their appointment or to see a pharmacist, is really important because they're poorly and they're queuing down the streets at the moment. So we need to make sure that proper facility for that is also made available.
All of these aspects are part of the evaluation of the scheme. And at the moment, we've had really enthusiastic uptake from pharmacies. We've had really positive feedback, generally from pharmacists and patients. And we need to properly evaluate what do the numbers look like, what's the feedback telling us, and then we review our ongoing approach.
Obviously, there are within the 7 conditions. There are some. I mean, infected insect bites are not going to be big news now, but that will happen as we get towards the summer. So that makes sense, right? So we said that this is about community pharmacy, our inquiry, but it's also we're interested in the secondary sector and hospital pharmacy. So Paul at Hamilton is going to touch on workforce, I think, but also on hospital.
Yeah, I just want to ask one question on workforce. I think Rachel covered it quite well, but there's an area that I'm going to ask the Minister and David if you could just answer it for me. It's just concerns over the extent to which pharmacy technicians are being pushed into the front line of pharmacy clinical practice. It's buzzing out there. People have got concerns. Now, my point is, it's been discussed by government, which we've heard today, that they want to give parity of esteem to pharmacy technicians. The clinical responsibility being given to technicians, which was previously undertaken by pharmacies, that actually they've got that underpinning degree, which technicians, no matter how you upgrade them, sending them on another course, they've not got that particular underpinning degree. But my concern is technicians are being represented to the public and to us as parliamentarians in the generic term of pharmacy professionals, which I believe is blurring the lines. And the other day when we had the issue around physician associates, I hope I've got that right, and what happened then, after a little while, the roles were blurred, and it did create a problem. And I'm just concerned with what we're trying to do with pharmacy at the pace we're going, what we're asking of technicians. It's just too much at this point. And what are you going to do with these independent practices that have got people lining up outside to come in? They haven't got enough staff. You've got pharmacy technicians asking to do more and more. They're coming out, maybe doing more than they're qualified to do. How are we going to stop the same thing happening in pharmacy that happened with doctors? And if I start with the Minister, and then I'll hand over to David.
Well, all I would say to that is that patient safety is absolutely paramount, and there isn't, as I've already said to Rachel, there isn't the blurring of the edges, there isn't an intention or even a carelessness that would enable pharmacy technicians to start practicing above their training. The idea is to improve patient access and patient convenience whilst retaining patient safety, and therefore to make the maximum use of the training levels of different professional people. And I actually would say it's extremely unhelpful when parliamentarians somehow suggest that this is some kind of Wild West or free-for-all, because that simply couldn't be further from the truth. But perhaps, David, you'd like to provide some more reassurance.
But also, I'm not saying it's the Wild West. Let's just get it out there. This is what is coming from pharmacists. And at the end of the day, we have recently had an issue with our doctors, with the associates. And at the moment, we are pushing down the road. Are we listening to what our pharmacists are saying? It's not the Wild West. I've known you for years. Don't do the jibes. At the end of the day, there is an issue out there. Answer the question. Don't jibe me, please. Thank you. David?
I hope I can provide some reassurance on those matters. So to the first point you mentioned, the reason for just framing it as a pharmacy professionals collective term is because both professions, both the pharmacist profession and the pharmacy technician profession, are regulated by the General Pharmaceutical Council. So both professions are in regulation. That, I think, is a very important backstop and explanation of the patient safety context in which we operate, because these are not unregulated workforces. These are both have to be registered with the General Pharmaceutical Council to practice, and are subject to the fitness to practice standards that the regulator imposes. So that's the kind of first level, I think, of reassurance. The second level of reassurance is that where we're looking to enable skill mix to operate properly within pharmacy, Department of Health has, Social Care has just completed its consultation on supervision, pharmacy supervision, and is considering the responses. Now, that sounds a little dry, but supervision has a very specific meaning in the world of pharmacy, and it's framed in the legal description of what activities must be undertaken by a pharmacist and what may be undertaken by other people. That's a very unusual position to be in. In most professions related to medicine, the bulk of that definition is held in regulatory standards, not in law. So the department's consulted on changes that would enable supervision to be more of a matter for regulation and professional standards than being a matter of law, because case law tends to interpret supervision very narrowly. So it means that somebody must almost be sort of looking over what you're doing, when in fact it's the purpose of it is to put in place safe systems of operation and to have a framework of governance to enable one to operate effectively, but also to, if you like, delegate certain tasks appropriately to other people. So that consultation has just closed. It's attracted a lot of response. I think government will consider its next steps in relation to that. But I suspect that consultation may have been the thing that's triggered some of the feedback that you've heard from.
There's been a lot of feedback.
Pharmacists in particular. And so that's the second level of reassurance, both in regulation, changes to supervision, but those changes relate to operational processes such as the assembly and dispensing of medicines. If you like, the bit that's important for the pharmacist to do is around the clinical judgment of whether a prescribed item is appropriate or not. That bit isn't threatened by this change. This change, if it goes ahead, is about enabling oversight of the technical elements of a process to be appropriately delegated, if you accept that terminology, to registered health professionals who can then undertake it on behalf of the pharmacist. It's not about blurring that sort of clinical interface that the pharmacist may have with the patient in a sort of consultation. Now, the other thing I ought to mention is that quite a lot of the debate, and you may have picked this up, has been about entry-level qualifications, not the qualifications one develops over one's career to better discharge the responsibilities you have. So quite a lot of what we've referred... So you may be aware there's been another consultation recently about the ability of pharmacy technicians to join the group of healthcare workers or healthcare professionals who can operate under PGDs. That's a recently closed consultation which the department's been considering. And again, in that context, these are not about day one roles. These are about roles that one develops into through a course of professional development, which you can then undertake at some point in the future when you have the necessary knowledge, skills and qualifications to do that. And I think in sort of reassuring pharmacists and the public more generally, this is about appropriately skilled people being empowered to do the right thing. It's not about blurring boundaries. And I think maybe I'll just conclude. It's been a bit of a long answer, sorry, but just to conclude that I'm not sure if it was your question, Rachel, about identity. How does the public know who they're dealing with? And I think there is an important element to this.
And it's massive. Important
element about people wearing sort of badges or other indications that define the role they provide, so that the public knows who it is who they're speaking to when they enter any premise. And my background has largely been in hospitals, and it's a great deal of effort there goes on to make name badges where they're on contrasting backgrounds, so people with poor sight can see them. They're suitably large. They describe who you are. And that's your contribution to this very sort of multi-professional environment that we all work in. So
just to end that bit, because I haven't got very long, my last point on this subject is Healthwatch England have also been calling, they've also been voicing concerns in this area. My last word would be, please let us work together and listen to what other people are saying to ensure the same mistakes aren't made that was made with the doctors. So we start off the way we mean to go on, and we don't just push people into doing things that perhaps they're not ready to do, or perhaps can lead us down the road where we are with the doctors right now. That is the only point I'd like to make, and I'd like to move swiftly on. And I'd go back to the Minister, please. What is NHS England's ambition for the future of hospital pharmacy, Minister?
Well, that actually, I'm sorry to say that actually isn't my portfolio, and so I will defer to Amanda to talk about the future ambition.
Thank you. Amanda?
So, not wishing to appear unhelpful, it's also not my portfolio. I'm primary care. But obviously there is, it's a pathway, isn't it? Patients go in and out of hospitals and receive medicines across both. So if it's a technical information about what happens in hospital pharmacies, David is the person and he's the expert. If it's about things like discharge medicines, then I'm happy.
Well, I'll tell you where I'm leading. We went to Cleveland and we saw some really good work in Cleveland. E.g., we saw the closed loop medical system, including the barcoded medication and automated dispensing cabinets. It was excellent, absolutely excellent. What I'd like to know is, where is the rest of the NHS? Where along are they with all of this? Because I would love, before I die, to see this across the NHS, because they were an excellent exemplar.
So the good news is that those facilities are available in some NHS trusts now. There are 11 global digital exemplar NHS trusts that have some form of closed loop, which is the process you will have seen at the Cleveland, the closed loop approach to provision of medicines.
Presumably Frimley would be one of them.
Frimley, Cambridge University Hospitals is a very advanced sort of demonstration of that process. So it is good news that we have that sort of ambition within the health service. It's been spurred on, I think, much by sort of local champions, and what we haven't had to date is a more systematic approach to things like automated medication storage, robotics, and to contrast that with the sort of investment that has been made around electronic prescribing and medicines administration systems, which is also part of the same story. The powerful thing, I think, about the barcoded medicines administration that you will have seen is the ability, if you like, to scan the patient, scan the product, and then the electronic prescribing system tells you that you've got a match between your intended recipient and the product that they should be receiving. The other thing that Cleveland will do is unit dose dispensing, which is the packaging of sort of individual doses. That's not really an NHS approach to the provision of medicines at ward level. We are much more focused on providing original packs of medicines, so outers of 28 tablets, for example, because unit dosing is very labour intensive, and I think probably Cleveland requires 24-hour verification of all doses that are about to be administered, and again that has a significant workforce consequence if you're expecting somebody to sort of verify remotely every medicine before it's administered. But the important parts of what you'll have seen about the closed loop element, I think, does have direct relevance to the NHS. And of those 11 global digital exemplars, there are at least another 4 or 5 trusts who are not part of that group but have also instituted closed loop processes.
So just to move this on just a little bit before handing back to the chair, to what extent are designs in new hospitals considering pharmacy infrastructure, like what we've just talked about?
So there's 2 important connections with the new hospital programme. One is exactly what you've mentioned around automation and the use of automated cabinets in clinical areas, but also dispensing robots in pharmacy areas. The second element that's relevant to the new hospitals programme is the aseptic services transformation, which is this initiative to provide more medicines in a ready-to-use form from regional hubs that can be delivered to hospitals and then taken to clinical areas, and the product is ready to go. It doesn't involve the nurse having to manipulate and reconstitute, as we would say, mix an injection, a dry powder injection with a diluent in order to create the injection or to draw it up to give an infusion. It presents it in a ready-to-use form. And there are big advantages around reducing error, but also liberating nursing time to focus on direct care for patients rather than being in preparation rooms making infusions and injections to be administered. So those two things are being considered within the new hospital programme. The automation and also the sort of needs to be able to accommodate ready-to-use medicines in clinical areas that might come from regional aseptic hubs.
I'll stop you there and I'll hand back to the chair.
Thank you. It's interesting because the thing about being a health minister, as I remember, is that everyone has their portfolios, but everything is also everything else, as you well know, which is why it's so exhausting. Yeah. And imagine being Lord Markham, who has everything in the other place. But you understand the challenges of getting the meds right to getting people out of the acute setting, and that, of course, is as much primary care as it is secondary care because it becomes that issue. Yeah. I just wonder, how are we getting on with the idea of having a pharmacist in all emergency departments? And the Royal College of Emergency Medicine were very keen on that and were pushing that as a campaign, weren't they? Are we getting anywhere with that? Does anybody know?
We have access to the NHS benchmarking network information from acute providers. And on that topic, about 45% of hospitals who responded said that they had a clinical pharmacy service in emergency departments. Right. So it's not universal, but it is a significant step towards the provision that the Royal College of Emergency Medicine was recommending in their guidance.
Okay. Then a couple of final things for the Minister, and I'll just see if any colleagues have got any other final thoughts. Hub and spoke, Minister. Mm-hmm. The government did a big consultation called Hub and Spoke Dispensing, which closed at the end of September last year. Yeah. I just wondered if, just for those watching who may not be, total experts on this sector, what do you understand Hub and Spoke to be, and what are you being told by your officials as to when, if we will see any response to the Hub and Spoke consultation, to which a lot of work went in?
Yes, absolutely. Well, certainly the ambition of Hub and Spoke is to make the dispensing process more efficient and thereby free up pharmacists' time. And at the moment, Hub and Spoke is already allowed within the same legal entity, but there has been a consultation to enable Hub and Spoke dispensing between different legal entities that took place in 2022. Yeah. And I fully expect to publish the government's response to that consultation shortly. I've not seen the sort of collated analysis on Hub and Spoke, but certainly, again, talking to colleagues who come to me with issues such as, they have a chain of pharmacies and not all within the same legal entity, and therefore they can't use the Hub and Spoke model, which they find to have useful economies of scale within the store or stores that aren't part of the same legal entity. So I think that there will, in principle, be some advantages there, but clearly it is designed for efficiency.
I just wonder, given all the changes that we've talked about, workforce changes, supervision, and not least Pharmacy First, is Hub and Spoke biting off a little bit more than the sector can chew right now?
Well, I think because it's already used, it's already been in place for some time. So actually the consultation is only on whether to allow that same model to exist where there is a branch that's not in the same legal entity. So I don't think it would be a revolution. I think it would be an incremental improvement in the process that enables that efficiency. And at the end of the day, it would be about time saving and better use of resources. So I think, but as I say, I've not seen the collated response to the consultation, but perhaps, David, you have.
Any thoughts, David?
Nothing further really to add, Chair, at this point. I think, it's under consideration, I think, is the phrasing at the moment.
Okay. And then, just finally from me, Minister, NHS England announced, or maybe both of you, announced that something called the Community Pharmacy Cancer Pilots in June 2022 was described then as, quote, radical action on early cancer diagnosis, and it was about trialling community pharmacy direct referrals into diagnostic services, as I understand it. And Amanda Pritchard, the CEO of NHS, sort of launched it at the Confed Expo in Liverpool in 22. Just wonder where we are with that, because it feels like quite slow progress, and I think we've got fewer than 10 pharmacies signed up to that pilot. Is it still something that you are keen on? Could you update us?
Yes, so it's definitely something that we're keen on, but of course it is a pilot, and it is again designed to improve that pathway. And the question is, will that work? Is that going to be a successful way to identify and get people into a cancer pathway sooner, or will there be lots of false positives, or indeed, reassurance to a patient where there shouldn't have been? So I'll leave Amanda to talk through the details. But
what's the thinking? That pharmacists are their front door, shop front, they're seeing people all the time who may be coming in with regular persistent cough, looking for a cough linctus, and that may be a flag, and they then make a referral. Is that crudely put?
That's what the thinking started with, yes. So essentially, as I said earlier, we have twice as many pharmacies in deprived communities as we do in the average across the country. We know that people living in deprived communities are significantly more likely to have their cancer diagnosed at a later stage. So for these communities, it's doubly important that we take any opportunity at all to pick up worrying signs and symptoms early and get people into the right pathways. And so that was the initial thinking. Pilot has started. The initial work of the pilot is about... So we haven't sort of worked it up in detail and then rolled it out so much as the initial pilot sites. So there's 4 pilot sites in total. Cornwall and Norfolk have started, soon to be followed quite soon with Greater Manchester and South East London. And the initial work has been on, so which are the cancers that are most likely to present in this way? What's the pathway? What are the list of symptoms we should look for? And how does that link into the local cancer pathway? So what's the mechanism by which community pharmacists refer in, having flagged these symptoms? So the thinking is all the pilots will focus on lung cancer, because that example you gave, people keeping coming back for something, for a cough, that's a flag. The other 2 pathways that some but not all of the pilots will be testing out for us around head and neck cancers. So someone who keeping coming back with a sore throat recurrently, or swollen glands, or those sorts of things. So or a sore mouth. So people who have symptoms that, as a one-off, presenting to a pharmacy for advice or some over-the-counter treatment is fine, but if the same person keeps coming back with those things, that raises a red flag. And then gynecological cancers. Right. So people might be asking about, I've got this, is this a normal side effect of my HRT, or those sorts of questions. So where symptoms are flagged to pharmacies more commonly than others, that might be a good pathway in. So work is ongoing. We have to get this right. I mean, it goes back to, this is not about replacing GP surgeries with pharmacies or passing people around to different services. This is about opportunistic identification in high-risk places of people who might have worrying symptoms. And don't forget, our aim is to have a really low conversion rate for cancer pathways. So we want to have many, many more people referred in than actually have cancer, because that's the best way to not miss cancers. Mm-hmm. And that's the best way to get them diagnosed at an early stage when they're treatable and potentially curable. Mm-hmm. So that's where we're up to.
Interesting. Any colleagues wish to come back in?
I just had one further question. It's a question for you, David. This committee gets very excited about looking into the future and what's coming down the stream, and particularly because we know that there can have a transformative impact on patients and their futures. I asked a parliamentary question around the use of AI within pharmacy and got a response that the department wasn't looking at areas at the moment. Could you perhaps set out what that future technological landscape looks like, in particular how AI could be deployed within the profession?
Yeah, happy to sort of speculate a bit on the future. So the sort of technology elements run from the things we talked about previously, the automation and the digital systems that support them. And of course, once you encode information within a digital system, you create a rich environment for processes like AI to interrogate the data and look for patterns within that. And I think there's probably a fundamental clarification to make between what we might call decision support and AI. So decision support is the sort of thing that guides you to the right dose or the right adjustment if somebody's got renal failure, those sort of things. Whereas AI is a bit more liberating in the sense that it can kind of crawl through the data and identify patterns for the future. And I think that the sort of records that pharmacies keep about dispensing of medicines and the presentation of illness will be a ripe area for that, as it has been in medical practice, where it's used to interrogate radiographic images and provide sort of diagnosis or diagnostic advice to clinicians. That seems to be of a very high standard. So I think it's part of the future, and it probably joins things like genomics as well in terms of that sort of predictive element. So, healthcare can be quite reactive, can't it? It can intervene and then see what the response is. In the new era, I suppose is what I'm saying. In the new era, things like AI will predict the kind of response we'll see, and genomics will predict our response to medicines. So it will tell us not only the precise medicine that we might need, but also if we do have an adverse reaction, or at least it will help us avoid adverse reactions because we will know somebody's genetic makeup that predisposes them to an adverse reaction. So I think in the round it's a very exciting future when you couple that sort of intelligence aspect with the automation and the digital systems that underpin it. Then I think we're on the verge of something transformative at that point.
Yes.
Can I just add to that? Because I completely agree with you, but in talking to GPs who worry about the number of medicines that people are taking, particularly with an ageing population, and I think AI could actually be incredibly useful there, because I was talking to some GPs recently who was saying the trouble is you give someone a drug and then you give them a drug to offset the side effects of that drug, and then you need to give them, and before you know it they've got a cocktail of drugs, and actually sometimes sight is lost of quite how many drugs people are supposedly taking, and then of course you get the patient decides, well actually I'm not going to take all of those, I'll just take some of them, which is a potential disaster. So actually AI has, I think, a really important role in a sort of constant drug review, medicines review, to just try and make sure that you're not actually just overloading somebody unnecessarily.
Fantastic.
Right.
Next time I ask the question, I expect a different reply then. So to know that the department's investing in this technology.
Yes.
Thank you.
When Rachel says excited about, everything is relative in life. I just think I should clarify that. Anyway.
I'm excited.
She's right.
We get excited about lots of things. Not least you coming in to see us, Minister. So thank you very much. There's Andrea Leadsom, thanks for coming in. David Webb, Chief Pharmaceutical Officer. Dr. Amanda Doyle from NHS England. Really nice to see you all. That concludes our inquiry on pharmacy. We will now produce a report, which I hope you will take a look at when it lands on your desk. But that's it for today. Have a nice Easter to all three of you. Order.
Thank you very much.
The proceeding has ended. The proceeding has ended. The proceeding